Hello class. Today we're going to talk about chapter 6 in your textbook, which is anesthetics and narcotics. Be an interesting discussion. So today we're going to go over the nervous system, anesthetics, pain management, migraine headaches, complementary and alternative therapies. Our learning objectives are to understand the divisions of the nervous systems, their functions, and their interactions with drugs. Learn how drugs affect body systems and where they work in the body. Understand the concepts of general and local anesthesia and know the functions of these agents. Define the action of neuromuscular blocking agents in reducing muscle activity. And understand the different schedules of narcotic and non-narcotic combination drugs and the role of the technician in monitoring these drugs. So the nervous system, the anatomical divisions of the nervous system are the central nervous system and the peripheral nervous system. Your book goes into detail on that on page 158. But the central nervous system is composed of the brain and spinal cord, and the peripheral nervous system is composed of the nerves and sensory receptors. So within the nervous system, there's the afferent system and the efferent system. The afferent system transmits information to the central nervous system from receptors, and it's broken down into the somatic sensory and visceral sensory. The efferent system sends information from the central nervous system to the body, and that's comprised of the somatic, motor, and autonomic. So on page 159 of your book, there's this figure of the autonomic nervous system. It's broken down for you in pretty good detail. So the nervous system, or nervous tissue, is a chemical signal is received on cell body and dendrites, and then the chemical signal is then converted to electrical signal or impulses. That impulse travels down the axon to the axon terminal, and then the axon terminal releases neurotransmitters. This goes into more detail on page 160 of your textbook about that. So there's different neurotransmitters listed here. One that we've talked about previously in pretty good detail is acetylcholine in the previous chapters. But there's dopamine, epinephrine, norepinephrine, serotonin, glutamate. These are all different neurotransmitters. The mechanism of action for neurotransmitters is they response of various adrenergic receptors to epinephrine or norepinephrine. The alpha receptors, they constrict blood vessels and provide decongestion. Beta-1 receptors increase heart rate and contractive force of heart, and beta-2 receptors are in charge of dilation of bronchial tubes and blood vessels. Anesthetics. This starts on page 161 in your textbook, but the role of therapy in anesthetics is to inhibit pain or the conscious perception of pain. General anesthetics provide reversible loss of consciousness and perception of pain. Local anesthetics block transmission of pain signal to the central nervous system from a specific anatomic site. So like if you had a headache, for example, you would take a local anesthetic to dull that pain. Choice of anesthetic is determined by clinical need and patient safety, and an anesthesiologist oversees administration of anesthesia during surgery. General anesthesia actions include unconsciousness, analgesia, or relieving of pain, skeletal muscle relaxation, and amnesia on recovery. General anesthesia assessments include blood pressure, plasma volume, oxygen level, pulse, respiratory rates, tissue perfusion, and urinary output. Those are all things that are monitored with anesthesia. And general anesthetics are pre-anesthetic medications. Narcotics alleviate pain and depress the respiratory center, and benzodiazepines provide sedation, amnesia, and anti-anxiety effects. So malignant hypothermia is a risk with general anesthetics, is a rare but serious side effect of anesthesia, and sudden and rapid rise in body temperature with irregularities in heart rhythm and breathing. Life-threatening and must be treated immediately, and is treated with dantrolene and a skeletal muscle relaxant. 163 goes into more detail in your book, page 163, about malignant hypothermia. Inhalant anesthetics are stored in steel containers such as compressed gas or liquid. They're inhaled through a face mask, and the respiratory system excretes 80 to 90% of those. The side effects include a drop in blood pressure, an increase in fluid in the blood, and drop in renal function, nausea, and vomiting. If you've ever had general anesthesia, you know when you come out you feel pretty crappy. Here's some examples of general anesthetics that are the inhalant anesthetics, such as nitrous oxide and enflurane, isoflurane, desflurane. These are all ones that you're going to see used quite often in the hospital. Injectable anesthetics, these include the ultra-short-acting barbiturates and benzodiazepines. The distribution is very lipid-soluble. They initially distribute to the brain, liver, kidneys, and later to fat and muscle. And body distribution lowers concentrations. They're usually administered via IV drip. These include etomidate, fentanyl, and the fentanyl analogs that are listed here, Altiva, Sufenta, and Alfenta. Ketamine, propofol, methotrexate. These are ones that you're going to see used pretty often if you ever work in an IV room in a hospital, especially like UK, a larger hospital where a lot of surgeries take place all day long. You're going to see these administered pretty regularly. So general anesthetics provide reversible loss of consciousness and perception or pain. True or false? That is true. And Ultane is an example of an inhalant general anesthetic. Is that true or false? That is also true. Propofol is an example of an injectable general anesthetic. That is also true. Tell more about the injectable anesthetics. Benzodiazepines, such as diazepam, lorazepam, or midazolam. These are often used as well in general anesthesia. Goes over this more in page 170 of your textbook. Antagonists to reverse overdoses. So in case you were ever accidentally overdosed with an analgesic or a sedative agent, the most common drug that's given for overdoses is naloxone, and I'm sure you've probably all heard about that. That drug is also used for illegal drug overdoses as well. It's an antagonist, and it competes for the opiate receptor sites. So it's really interesting, but your book goes into more detail on that on page 171 if you wanted to take a look at that about Narcan. Neuromuscular blocking agents. Their therapeutic uses include paralyzing skeletal muscles during surgery and adjunct to general anesthesia and endotracheal intubation. Safety concerns. They are dangerous since administration results in immediate skeletal muscle paralysis. They should be distinctly flagged during storage, and they shouldn't be stored next to look-alike, sound-alike drugs. So most neuromuscular blocking agents must be refrigerated and are very expensive, and failure to store them correctly could be a very costly mistake. These include succinylcholine and Nimbex, which is one that you're going to use very often in a hospital IV room. You'll be making that one a lot if you ever work in a hospital IV room. And vecuronium is also one that's pretty common. So neostigmine and pyridostigmine. These are also ones that are used to reverse neuromuscular blocking agents. So flumazenol can be used to reverse the effects of midazolam. Is this true or false? That is true. And neuromuscular blocking agents paralyze skeletal muscles during surgery. That is also true. Most neuromuscular blocking agents must be stored in the refrigerator and are expensive. That is also true. So local anesthetics produce a transient and reversible loss of pain, temperature, touch, sensation, proprioception, and skeletal muscle tone in a defined area of the body. There's no effect on mental function. Epinephrine is commonly used to keep the local anesthetic at the injection site. Esters are short-acting and are metabolized by pseudocholinesterase in the plasma. Page 175 of your textbook goes into a little more detail about esters. And amides are longer acting and are metabolized by liver enzymes. So local anesthetics include benzocaine, chloroprocaine, tetracaine. Diclonine is something that you'd find in a throat spray that's available over the counter. Local anesthetics include, or the amides include bupivacaine, lidocaine, lidocaine and epinephrine combo, and lidocaine and prilocaine combo. So lidocaine can be administered with a patch, an adhesive strip, and it should be placed directly onto the dry, clean skin at the site of the pain. It's contraindicated in patients with a history of hypersensitivity to that local amide anesthetics. 176 in your textbook goes over that in a little bit more detail. Pain management. Pain is a general sense of the body, and as pain receptors are activated when a stimulus is sufficient to cause damage to tissues. That perception rises from the transmission of nerve impulses from these receptors. So pain is basically a protective signal to warn of damage or the presence of disease, and it's a normal part of the healing process. Acute pain is associated with trauma or surgery and has a beginning and an end, warns of a problem. Chronic non-malignant pain is caused, may or not be caused by the diagnosis. It usually lasts greater than 3 months and may respond poorly to treatment. It does not cease when an illness or injury is healed. And chronic malignant pain accompanies malignant diseases and increases in severity as the disease progresses. So if you have a patient with cancer, as the cancer progresses, so will the pain. Major sources of pain here, you have the somatic source or visceral, neuropathic, or sympathetically mediated. Narcotics are defined as a pain-modulating chemical that is generally an opiate. The effects include analgesia, sedation, euphoria, or dysphoria. The tolerance is typically develops to pain requiring dose titration. So as the longer you take hydrocodone, for example, the more your body is going to tolerate, and your dose will have to be increased accordingly. It also causes impairment of judgment and psychomotor function, constipation and nausea. That's common with all opiate medications. And symptoms of narcotic overdose include decreased respiration, decreased body temperature, decreased blood pressure, increased heart rate, and coma. Narcan can also be used for a narcotic overdose. So on page 179, there's this model of an analgesic ladder, and the World Health Organization is the one who provided this analgesic ladder. It's interesting if you want to take a look at it, but it goes from 1 to 3, and yeah, like I said, it's on page 179 of your textbook. So Schedule II drugs. The DEA regulates Schedule II drugs. They require an original signed hard copy of the prescription with a DEA number each time. That means no refills. Partial fills to be filled within 72 hours. So if you have a prescription for a Schedule II drug and let's say the patient didn't have insurance and they couldn't afford to get all of the medication at one time, you could do a partial fill of that medication. Say the prescription was written for 60 OxyContin. The patient could get the first 30 filled, and then the other 30 had to be filled within the next 72 hours, or that prescription was void. So specific computer requirements for electronic prescriptions, they have to be filled within a year of the original date. They can't be refilled. A Schedule II has to be ordered on a specific form, which is called a DEA Form 222. The form has a triplicate copy. One goes to the pharmacy, one goes to the provider, and then one goes to the DEA. The state regulations are usually very strict on Schedule II drugs, and they must follow the stricter rule whether it's federal or state. Addiction and dependence. Dependence is a physical and emotional reliance on a drug. Withdrawal when a drug is continued or the dose is reduced. And addiction is a disorder leading to continued use of a drug despite harm. The symptoms include preoccupation with drugs, refusal to taper off drug, strong preference for a specific opioid, decreased ability to function, forged prescriptions, frequent prescription loss, changes to prescriptions, unsanctioned dose escalation, and reports from patient of shorted medication supply may indicate addiction. So when you're on the job, especially in a retail pharmacy, and this last bullet here is things that you should look out for with regards to patient addiction potential. So these are medications that are used to treat addiction. On page 182 of your textbook, they go into more detail about these. So Subutex, Suboxone, and Adolafine are all ones that are pretty common for treating addiction. Narcotic analgesics are defined as an analgesic medication derived from an opioid. The dose requirements vary with pain severity and response to pain, age, weight, concomitant disease. Morphine is a standard against which all narcotics are measured. Their potency is intravenous and intramuscular. And then the side effects are mental confusion, a decreased alertness, nausea, vomiting, dry mouth, constipation, urinary retention, histamine release, vessel dilation, and bronchial constriction. Narcotic analgesics include Stadol, codeine, fentanyl, hydrocodone, hydromorphine, meperidine, morphine, Nubane, oxycodone, oxymorphone, Talwin, Nucynta. All of these drugs are listed on pages 186 through 191 of your textbook. So there's also combination drugs for managing pain. The way they work is they relieve pain centrally and peripherally. The purpose is increase pain relief through drug synergy and the limit intake of addictive substances. So they do have dose limits. Due to serious risk of aspirin or acetaminophen toxicity, the daily limit is 4 grams for acetaminophen. And the content of acetaminophen now is limited to 325 milligrams per tablet or capsule. Filling prescriptions or combination drugs. The strengths of both components must agree with the prescription. Schedule 3, 4, and 5 may be refilled no more times than 5 times in 6 months. And a C2 can never be refilled. It has to have a new prescription every time. So these are combination drugs that are listed here for managing pain. You'll be very familiar with these when you work retail, but you have acetaminophen and codeine, hydrocodone and acetaminophen, meperidine and promethazine, oxycodone and acetaminophen, oxycodone and aspirin, oxycodone and ibuprofen, and Tauin and X. So a patient is picking up a prescription for Lorcet. What is the non-narcotic analgesic in this product? That would be the acetaminophen. So Lorcet is a combination of hydrocodone and acetaminophen. What is the narcotic analgesic in this project? That would be the hydrocodone. And what control schedule is this product in? And that would be a C2 because of the hydrocodone. So migraine headaches are a severe throbbing unilateral headache accompanied by neurologic and GI disturbances that can severely affect quality of life and daily function. If you know anyone who has migraines, or if you have them yourself, you'll understand just the severity of them. I actually suffer from migraines, as does my mom and my older sister. They're pretty terrible. So the components of a migraine are prodrome, aura, headache relief, and postdrome. The aura is visual or sensory disturbances such as seeing flashing lights, shimmering heat waves, bright lights, dark halos in visual fields, blurred cloudy vision, transient loss of vision, and they usually last 6 hours and sometimes 1 to 2 days. The pathophysiology is the dilation of cerebral surface vessels and increased levels followed by decreased levels of serotonin, which is a potent vasoconstrictor. Risk factors include diet, stress, sleep habits, certain medications, hormonal fluctuations, depression, atmospheric pressure changes, and environmental irritants. I know mine are generally caused by a lack of sleep or high stress levels. Non-drug therapy is identifying and eliminating trigger factors in a quiet environment, sleep lying down in a dark room. The prophylactic therapy agents include anticonvulsants, beta blockers, calcium channel blockers, estrogen, feverfew, NSAIDs, SSRIs or antidepressants, and tricyclic antidepressants. I actually take amitriptyline for prophylaxis for my migraines, which is a tricyclic antidepressant. Abortive therapy would include simple analgesics, NSAIDs, serotonin receptor antagonists, and ergotamine-containing medications. These are all triptans, which are selective serotonin receptor antagonists. These are all indicated for migraine relief to be taken at onset. So you're going to see these a lot in a retail pharmacy. You have Axert, Relpax, Frova, and the list goes on and on there. There's a lot of triptans. These are listed on page 194 of your textbook if you would like more information on those. So ergot derivatives, the way they work is through vasoconstrictions, and examples of these would include Migranal and Ergamar. The side effects include nausea, vomiting, and there are some considerations and cautions to be taken there as well. Antiemetic agents, these are given as a supplement for migraine headaches. I have Zofran, which is a very powerful antiemetic. Most migraines are accompanied with nausea and vomiting. The way they work is they block neurotransmitters which cause nausea and vomiting. Examples of them include Reglan or Thorazine. Side effects include drowsiness with both, extra pyridomol effects, and orthostatic hypotension with chlorpromazine, and different cautions to consider there as well. Butorphanol is also used for migraine headaches. It's used as a nasal spray, and it's an opioid analgesic, but you can sometimes see that as an older drug that is used to treat chronic migraine headaches. You also have tramadol and butalbital with acetaminophen and caffeine. Those are listed on page 198 of your textbook. Caffeine is a central nervous system stimulant used in combination with other analgesics to treat headache. So caffeine is one of the ingredients listed in Excedrin migraine, for example. It's acetaminophen and caffeine and aspirin. It's also used to treat fatigue and drowsiness, and it shouldn't be used for more than 3 to 4 hours, more than every 3 to 4 hours. There are some side effects with caffeine and high caffeine consumption: rapid heartbeat, palpitations, insomnia, restlessness, ringing in the ears, etc. Capsaicin is also used to treat topical pain. Capsaicin is actually found in peppers. That's what capsicum is, the heat that you see in different peppers. Feverfew is used orally to prevent migraine pain. It improves nausea, vomiting, light sensitivity that is experienced during a migraine. And then you have cannabis as well. All right, the Chapter 6 summary. The general anesthesia is the condition of reversible unconsciousness and absence of response to stimulation. Neuromuscular blocking agents ensure that the patient does not move during surgery. Local anesthetics relieve pain without decreasing mental function. Pain is classified as acute, chronic, non-malignant, or chronic malignant. Morphine is the standard against which all other narcotic analgesics are measured. And treatments for migraine headaches are divided into 2 groups: abortive and prophylactic therapies. If you have any questions, let me know.